More numbing medicine. So we're getting ready to start our surgery here. Shot. What is that cable? That cable's in the way. Lift it up. Yep. And shot. Okay. So we're at left, we're going 4-5, correct? Left 4-5, everyone agrees? All right, you're doing great. Just hang in there. I know it's a little uncomfortable. All right. So step one with the Deuk laser disc repair is gaining access to the disc that we're trying to fix. Shot. And to do that, I use an X-ray machine, and we use some numbing medicine, which we've given her. Shot. All right. You need to have a Raytech here for me, okay?
Yes, sir.
How's our blood pressure? Well, whatever you can do to help me. Let me know if you feel discomfort, and I'll give you more medicine, okay? Shot. Yeah. Whatever you need to do to get that stuff circulating and working. Shot. Need to be a little further north. Shot. 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 You okay? This is the worst part, so once we get this done, then we can put you to sleep. All right. So we're lined up pretty good. Just need to get around this facet joint. Shot. You'll be able to watch the surgery afterwards. We'll give you a video of it. Shot. 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 Let me know when you're happy with the blood pressure. So our trajectory is not too bad. We just need to get a little bit more lateral than where we are. Shot. Shot. All right, I hear you. You're doing really good. Shot. We're right near your facet joint. We're right at the facet joint, as a matter of fact, so we're very close to where we need to be. Shot. Huh? Yeah. Shot. This is the worst part of the surgery for the patient, by the way. I apologize. I wish there was a better way we could do this, but I need your help in the beginning. Let's get some more local. Okay, you should have switched it already for me, okay? Why? That's right. I'm giving you a little more numbing medicine, okay? Do you feel it? All right. I'm going to give it to you on both sides. You're going to end up feeling it on both sides, okay? Shot. 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 very close. They seem to be lined up nicely. So I don't think it's an X-ray issue. Shot. Shot. I know. Shot. 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 All right. Feel like we're where we need to be. Almost done. Huh? What did she say? Yeah. Yeah, no. Thank you for the play-by-play. All right, AP. So we are where we need to be on the left side. I'm going to have to go over to your right side in just a minute, but I need about another minute. I want to verify everything on another view. So again, the first step is getting into the bad discs. Perfect. Go bilateral. And on the left side, we're going to be going to the L4-5. On the right side, we're going to be going to L3-4. So we're here to fix two discs that are damaged. Both of them are herniated. The L4-5 is the worst one. Let me know if you feel any discomfort. Where do you feel it? In your back? All right. Well, that's where you're supposed to feel it. So that's good. I'm going to go over to the patient's right side now to place the right-sided needle. So the left, everybody agree? You want to double check the consent? Left 4-5. Right 3-4. Everyone agrees. All right. Measure twice, cut once, right? Is that our lateral view? Yeah, that's good. That's perfect. Nice job, Jordan. You have lined everything up absolutely beautifully. All right. Are you comfy? I apologize for all this, but we're halfway done with the awake part, and then we're going to put you to sleep soon, okay? So I'm sorry you have to be uncomfortable for this, but this is what we do for everybody. I need your help in the beginning, because the reality is that there's some vital structures I'm going nearby, and I don't want to get too close. Yeah, I heard it. Shot. Let me have some numbing medicine. I'm going to give you a little more numbing medicine. Have you watched me do any of these surgeries? How many of them have you watched? 4? And I didn't scare you away with 4 surgeries? Okay. Your dad is a corpsman. So there's no scaring you away at all. Shot? 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 Again, we're going to need to get around the facet joint. Shot, like we did last time. Shot. 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 And I'm going for the L3-4 disc. Shot. Yep, I know. Shot. So close. We're almost done. I promise. Just bear with me a little bit more. Shot. 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 We're almost there. Very close, okay? Shot. And just for those of you watching and for the patient later to watch, every time I come out and go back, I'm actually redirecting this to go a little bit further forward, but I'm doing it at about 1 millimeter a time. Shot. Because what I'm doing is I'm bumping up against the back of the spine, which we don't want to be at the back of the spine. We want to just wrap right around the back of the spine to the front. So I'm hitting these facet joints, shot, and then I'm just bringing the needle around to the front of them. Just 1 millimeter at a time, 1 millimeter a pass, shot. So 3-4, we all agree that's 3-4, right? 5-1 there, 4-5 there. This is 3-4. Shot. Shot. You okay? Yep. As okay as you can be, right, for having back surgery and being awake? Right? All right. Well, that's what we're expecting. Shot. All right. So, how long have you had your back pain for?
Over
10 years. And you have it every day?
Yes.
So she has back pain for 10 years every day. And why are you having this surgery done?
Because I'd like to live my life again.
Because you want to get rid of the back pain, right?
Yeah.
And how has the back pain kept you from living life?
It's very difficult for me to walk or for me to do anything.
You what?
It's very difficult for me to walk.
Very difficult to do any activities, right?
I can't ride a bike. I can't walk.
What about sleeping? Does it affect your sleeping?
Not normally.
So you sleep pretty good as long as you're not moving around in bed.
I have an adjustable bed.
So basically, it's activity-related pain in your lower back, right? In this area in here, right? Are you having that pain right now?
A little. The more you push, the more I have. Okay.
How bad is that on a scale of 1 to 10?
I would say about 11.
11? I need an x-ray picture, guys. All right, very good. Very good. Please be careful with that. So you had an 11 out of 10?
Yes.
Is that where you typically get your back pain, in that area?
Yes.
All right. So that was 3-4, 11 out of 10. So we just tested the L3-4 disc, and indeed, if you look at the MRI, it doesn't look as bad as the L4-5, but there is a tear, an annular tear. And the annular tear is inflamed, and that's where her back pain's coming from. And she had 11 out of 10 pain here. Are you more comfortable now? I'm not going for a stroll. There's only one thing I'm coming over here for. Is it eased up, your pain? All right. Do you remember what this part of the surgery is? We call it a discogram. You remember seeing it in my prior surgeries, right? How bad is that on a scale of 1 to 10? Just give me a number. 15. All right, well, you get to go to sleep now. We're done testing. We found the source of your back pain for the last 10 years. And when you wake up, that pain will be gone. Won't that be nice? Yeah. All right, so we just did what's called an evocative discogram. And basically, we evoked her typical back pain. by injecting dye into the disc. Now, what does that tell us? It tells us that the disc is the cause of her back pain. Lay still. Don't try to get up. She's going to sleep now. And when she wakes up, surgery will be finished. It's going to take us about 30 minutes to do her surgery. Just count from 1 to 100 out loud for me and lay still. You're doing great. Everything is good. Count out loud for me, 1 to 100. So I'm going to have her count out loud. That way I can tell when the medicine is taking effect and she's asleep, because she'll stop counting. So until then, she'll be counting and I can hear her counting. Why don't you show them at L4-5, Jordan, where the tear is really bad in the back of the disc. We'll show you with a white arrow on the x-ray. You at the x-ray, Diego?
Yes, we see it.
All right. And then at L3-4, it's not as bad, but look at the disc at L3-4. That is not a normal appearing discogram. It should be a cotton ball. And that's clearly a big tear in that disc in the back there where Jordan's pointing to. That's a grade 4 tear. It's huge. And that's also the source of her pain. So she had 11 out of 10 pain at L3-4 and 15 out of 10 pain at L4-5. Both of the pains are her typical pain she gets every single day. So 15 over 10 at L4-5. Again, there's a giant annular tear and a herniated disc. All right, let me know when our patient is asleep and we can get started. So I'm going to use the x-ray to leave the guide wire in place at L4-5, but I want to get this needle out. Shot. All right, so taking out the needle, leaving the guide wire in place. Shot. You don't do that. You let me put it down. Grabbing for needles is never a good thing. Why? That's how people get poked. Okay? I need the knife blade. Good. Good. I'm going to use an 11 blade. We're going to do what's called a stab incision. Basically, I'm going to cut 7 millimeters of, which is a 1/4 inch, right here at L4-5, through the skin. 7 millimeters, okay? The whole surgery will be done through a 7 millimeter incision at L4-5. Then we're going to go to the other side and do the same thing for L3-4. Now down this guide wire comes the dilator. The dilator is like a long metal pencil. Lay still, you're doing great. Shot. So I'm going to give her a little bit more medicine. Yep. And I need the skinny. Where's the skinny needle?
Well, we understand. Well, you can try with that one, but yeah, it's for the cervical that we have.
All right, this will work. So there's a second port on the dilator to the side, and I'm just injecting a little numbing medicine in there to make it feel better for her. The problem is you don't want to put numbing medicine like when you're too close to the nerve root, because it'll numb up the nerve root, and then the patient won't be able to walk after surgery for a few hours. Lay still. You're doing great. Everything's good. Just lay still. All right, so now I'm basically in the foramen where the nerve root comes out, but I'm just below the nerve root. You got to put it in my hand, okay? Otherwise, I have to look away from what I'm doing to see what you're handing me. Okay, your job is to hand it to me. Yeah, when are you going to have her down? Uh-huh. No problem. Just lay still. Everything's okay. Are you awake? All right. We'll just give her a minute for our anesthesiologist to get her to sleep. We'll take any questions you might have. We're actually live streaming, broadcasting spine surgery. This is the most advanced type of spine surgery in the world for degenerative disc disease. We're not doing fractures or tumors or infections of the spine. We're not doing trauma with fracture dislocations. We're doing surgery for herniated discs, degenerated discs, bulging disc. So there are a lot of different names for disc injuries: bulging disc, slip disc, ruptured disc, protruding disc, extruded disc, bulging disc, herniated disc. I mean, the list goes on and on. It's incredible how many names there are for the same thing. In the end, all of those things mean one thing. There's a tear in the wall in the back of the disc, and the jelly from the center is pushed into that tear, causing back pain and leg pain. That is the herniation, and there's two parts to it. There's a part that's outside of the annulus tear, and there's the part that's inside the annulus tear. And the herniated material of the nucleus that's inside the annular tear causes inflammation of the annular tear. That causes back pain. The part of the herniation that's past the annular tear and rubbing on the nerve root past the annular tear, back there is the extruded part. And it causes leg symptoms, like leg pain. Our patient's had her back pain for 10 years. No one's fixed it for her. She's gone and tried lots of different things. None of it's worked. Shot? So she came to Deuk Spine Institute in hopes of getting rid of the pain. I'm just pulling the guide wire back a little bit. It's getting a little too close to the front of the disc for me. Just lay still. Shot? All right, now the dilator is going inside the disc at this point. We're going right through that tear. That's great news, because that's where all of the pain comes from. That's where her problem is. You're doing great. Lay still. Shot? So we're now inside the disc at L4-5. Lay still, you're okay. And we are inside the disc, and we went through the tear that she already had there. So I'm not creating a new tear. I'm going through the old tear, and that's why it's uncomfortable, because that's where all of her pain comes from. So I'm going through that area because that's what I'm going to fix. Lay still. You're doing great. Shot. Want to make sure the dilator doesn't come out. You're doing fine. Everything's good. She's not really awake. She's kind of half awake, but I'm still talking to her just in case she is. All right, lay still. You're fine. This is obviously a very uncomfortable disc for her. This was the 15/10 pain. So she's responding to the pain, moving her body a bit, grunting and making noises. We're going to get her a little bit deeper to where she's more comfortable. And of course, with anesthesia, it's always a delicate balance between too much anesthesia, where the patient stops breathing, versus too little anesthesia, where they're in pain. Let me know when I can proceed, okay, doctor? Take your time. No rush here at all. Just take your time. She awake? Should I wait or should I proceed? Proceed or wait? Go ahead. All right. We need to make sure she's strapped, obviously.
Yes.
Top and bottom. Yeah, she's responding less. So just so everybody understands, every patient's a little different with how they respond to the surgery. Some people just go to sleep and stay asleep. Other people kind of go in and out of consciousness with the medicine. And it's really important that we don't put people too deep asleep, because if they go too deep asleep, then they can stop breathing. Shot? And we never, never, never want that. Take that. So less is always better when it comes to anesthesia, but you don't want the patient moving around either. So it's kind of a fine balance between the two. All right, let's go ahead and get started. We're inside the disc. Can we just check her position here? Luis, will you reach under and make sure she's laying flat on the bed, not like laying off to the side? Check the straps again before I get started. need me to stop? You can wake her up a bit. Yeah, you can wake her up a bit. We're through the painful part.
You are? Okay. Now should be okay.
So you can let her come back.
Let her come back a little bit.
So, start working with
I
the,
think
make sure you
you're
control
okay.
the laser.
All right, let's get started.
Struggle with your laser.
All right, I need the scope on. Where's Jordan? I need
It's on. Please, can you change the video monitor?
I'm sorry, what?
is that her moving or are you moving her?
Michelle, you're okay. Now you're okay.
Everything's okay. Lay still. Hey, Luis, did you check the scope?
Yes, sir. What is it?
Did you check this scope? Give me another scope.
Yes, sir.
I don't know if it's some tissue.
Can you turn on the suction canisters,
Suction canister on, please, Jordan. Now. Are you guys doing okay? All right. Luis, you don't have to open it yet. I think we're okay. You don't have to open it yet. Just keep it in the room. I'm not sure what's accounting for the blurriness, but let's go, dude. I need that laser fiber. Lay still. I need the pedal. You at 30? All right. Okay, you can't do that, okay? Because I need to rotate this wire around. So you need to hold it like this, and you need to give me the ability to do that. If it was as easy as piling things on top of the fiber, anyone would do it, but it's not. How you guys doing over there? Stand by. There's a piece of herniation there. All right, so far everything's going well on the surgery side. Patient's just, we're trying to get her comfortable, and again, we don't want her to be too asleep, otherwise she won't breathe. So it's a delicate balance between enough sedation, keep her comfortable, and keeping her breathing. It's a tug of war. By the way, you can see the tear there. I'm not sure why, but there just seems to be a lot of, I think the reason why is there's a lot of blue dye in the water, in the irrigation, because I put in a lot of blue dye. You need to have that thing turned around the other way, so you're not having to rotate it when you hand it to me. Is that understood? All right. So that's why the visibility is not better than it is. God damn it. I'm having trouble rotating this. Just, you got to get all that off of it. Huh?
I'm trying to put something on it.
You don't put anything. Put your hand on it and control it properly. The moment you lay something on it, it doesn't roll. Do you understand what rolling is?
Yes.
Tell me what rolling is.
Circulating around itself.
Yeah. So when you put that wet towel on it, how is it going to roll? Think about it. Do you have an answer?
We just usually do it, but I guess I'm not doing it right.
No idea. Normally I don't have to pay attention. Lay still. You're doing great. So what we know so far is that the L3-4 and L4-5 discs, which I identified based on her physical exam in the clinic and based on her MRI, are the cause of her back pain. And they are. We know that because of the discogram we just did to confirm that fact. So I have the source of her pain being these two discs. Now I just have to repair them. And it's a bit of a race against time. We need to keep the patient safe, breathing, but also comfortable during the procedure. So while she's sleeping, I'm trying to get the surgery done. How is she? Do we need any additional help? Once I get this tear cleaned up, we'll be done with this disc. This is all that part of the surgery that helps with the pain right here. This is the debridement of the annular tear. We guys okay? What's wrong? Luis, everything all right?
Everything okay. I just, we don't know if we want to call Rita or another nurse just in case.
Why is my irrigation so low? Get Rita in here. We have plenty of nurses. There's no reason for there not to be one in here. Is the end title good? As long as my anesthesiologist is happy with the end title. Stand by. How's the irrigation? God damn it. You didn't get this on all the way. Okay. Yeah, right now I'm seeing good. That red stuff right there is inflammatory tissue by the tear near the outer annulus, which is where there's blood vessels. So that's what we want to see. That's what we want to zap away. Every bit of that we can get out is going to help her with her pain in her back. Are we doing okay, guys? I need to hear from my anesthesiologist. Okay. You're happy? It's taking too long for you to give me that. You're too clumsy. You know what you can do? Huh? No. Yeah, you can be better prepared. But how do you be better prepared? I'm going to show you, okay? Help you out. Just give me a second. There's a nice piece of herniation there. Did you get it? You didn't get it. What? I couldn't hear what she said. Am I missing something? Where is the other nurses? like this. Huh? Well, we need to get Rita out of the meeting. No, I appreciate your opinion, but I want Rita out of the meeting. I want her here helping out. The moment you grab that and start twisting it or not getting it off properly is the moment that it gets trapped on my finger. You understand?
Makes sense.
So you can't even start twisting it or pulling it. You have to lift it off. That's the first movement. The very first force that you have to apply is a lift. You know how to do that?
Yes.
All right, let's see if you do it. This is all the scar tissue from chronic inflammation in the annular tear from that blue stuff right there I'm zapping out, which is the interposed nucleus material that's causing all of her back pain. Oh, yay. Is she coming? She's here, right? Huh? We're doing good. Hey, Rita. We were looking for you. Well, we'd like you here helping us. Do we have 2 nurses in recovery, PACU, whatever? Yeah. So when she said there was a patient in PACU by themselves, they weren't by themselves. Oh, so someone's on lunch break. I'm just trying to understand. Rita? All right. Hey, nice job. You're getting it down, little gunslinger. There you go. Call Karen. Is everything okay? She's what? I couldn't hear, but as long as we're fine, we're good, right? Now, for some reason, the laser rate just jumped up. It's definitely... How did that happen? That's fine. I mean, it's fine. It's just, it was an obvious difference. It was like going from doing the waltz to doing, you know, the lambada or the merengue. All right. So anyway, I'm just using the laser to debride the tissue. Diego, I thought we had a question last surgery about how does the laser actually work? What's it really doing?
Yes, we did have a question.
Right?
Uh-huh.
Well, the laser delivers energy, guys and gals. The little thing you're seeing down there at the end of the blue is actually a glass pipe. And the glass pipe goes, it's like a glass pipe. It goes from the laser machine, which is basically at the foot of the bed. And it's a big machine. It creates laser energy. And basically it sends that laser energy along this little glass pipe that's insulated. And the energy comes out the end, but it doesn't go very far out the end. It only goes 0.5 millimeter out the end. So think about a half a millimeter. Even if it went a millimeter, it wouldn't be very far, but it goes half a millimeter. Now, to give you an idea of what's half a millimeter, you see this tube we're working in? It's got a circular metal tube. That tube is around 6 millimeters from end to end, side to side. So that gives you an idea of just how magnified the view is that we've got right here. All these are chunks of herniation. She's not liking it, but she's, this is the painful area of the disc. This is what we're after. We're here to do a job, and if we do it well, that pain she had before surgery will be gone. And that's what I'm expecting. Don't do that. Come on, man. Use your brain. Control your movements. Is she okay? All right. So, where did I learn to control my movements? Where does a neurosurgeon learn to control their movements? Anybody want to venture a guess? Let's see who knows the answer. Video games. Ding, 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 ding. Absolutely. The answer that most people don't expect, but it is the truth. Surgeons that play video games have very good hand-eye coordination. As a matter of fact, the best surgeons in the world have been shown to be video game players. Okay? That doesn't mean we play video games during surgery. We played video games in our adolescence. Okay? We played a lot of video games. We learned hand-eye coordination. You learn to get punished by the video game for making the wrong move, right? So whatever video game you're playing, if you go left instead of going right, you basically lose. So if you're a good video game player, you learn to control your movements, you learn to plan ahead, you learn to really make your body do what it's supposed to do, like very controlled movements, and a lot of forethought and foreplanning. So the frontal lobes develop quite a bit in a good surgeon and a good video game player. So if you're a good video game player, there's hope for you yet to become a neurosurgeon. Okay, you should have this here to prevent the water from dripping down onto my feet.
Yes.
Which you don't have. Does that mean you don't care if my shoes get wet?
I do.
You know what happens when my shoes get wet?
They squeak.
They squeak and I squeak. No, what happens is when I get home, my dogs start to sniff and lick my shoes. You know what? You had to hear it, right? I'm sorry. I don't bring them home steak. So are you going to remember not to let my shoes get wet?
100% from now on.
Good. You're going to have that image of my dog sniffing and licking my shoes, aren't you? Just about done here. This is the L4-5, then we're going to go do 3-4. I can tell you right now, the L3-4 is not going to be as damaged as the L4-5. The L4-5 is in bad shape. I can see lots of bone spurs here. So the laser basically delivers energy to the tissue, and by doing so, it disrupts covalent bonds. All organic matter is held together by bonds. Atoms are held together by bonds. I mean interatomic bonds between different atoms. Nitrogen bound to carbon, carbon bound to hydrogen, and organic life forms all have carbon-based life forms. That's what makes them organic in the world here in Earth, is that they're based on carbon. We call it carbon-based life forms. That's organic matter, organic life forms. So you have these bonds between carbon and nitrogen, carbon and sulfur, carbon and hydrogen, oxygen and hydrogen, and most of the bonds are what are called covalent bonds. There are also ionic bonds, and there are other types of bonds like van der Waals forces. I thought maybe I heard somebody mention that. But the laser energy goes in and basically breaks up those bonds between tissues, between molecules, intermolecular bonds. That's what the laser does. Ladies, just about done here. I mean, I just need a little bit more to get just the rest of this stuff here. Okay. So someone had asked, how does the laser work? By delivering such intense energy to the tissue, it breaks up the bonds that hold it together. You guys remember playing a game called Red Rover, Red Rover? Remember when everyone formed a line and they held hands as hard as they could? Those hands are bonds between people, like between molecules, let's just say. And then someone from the other team would come over and they would try to break through your bonds between your hands and snap the bond. Well, that's what the laser does. It snaps the bonds between molecules inside the tissues, like this disc herniation or bone. And there's so much energy delivered that it would be like, honestly, like a bull coming over on Red Rover, Red Rover. And the bull is going to break right through your hand bonds very easily. So the laser can disrupt bonds, covalent bonds between tissues, and break it into pieces. And those little pieces are what cloud up the water you're seeing. That's why it's so hard to see. It's very cloudy because it's all these little pieces of tissue that are being vaporized coming out and clouding up the irrigation. How are we doing over there? Good? Well, we're definitely going to need more irrigation. God, I got a whole puddle down here. So, anyway, the laser also delivers some of its energy to the water or irrigation. It's not really water, it's saline. That's you're seeing here. It looks like water. And the laser is delivering some of the energy to that liquid water, and it's causing cavitation, or basically pressure waves. And those pressure waves are also helping to break up the tissue. We have any questions, Diego?
Yes, we have a question from YouTube. We have an orthopedic surgeon who is asking, can I take a course at your facilities?
Can you take a course at our facility?
Yes.
So the answer is yes. You need to contact me to make those arrangements. I would like to know where you practice. Are you board certified? Did you finish your training? When did you finish your training? You know, so there's some criteria that would need to be met before I train you. Lay still, you're fine. And once I get that information, then we can make a decision. But I don't just train anybody. I'm only going to train people that I trust are going to do a good job with the patients, people that are trainable. Believe it or not, there are doctors that are not trainable. They think they know everything. And so it has to be somebody who's qualified and somebody with the right personality to learn new things. It sounds like this doctor is already saying that they're willing to learn new things, so that's a good start. But I have to see what kind of qualifications they have before I would agree to train them. Training is not something you can do just watching. It's hands-on. And obviously I can't let someone be hands-on with my patients unless they have the right training before they come here. So we do offer fellowships, but it's for doctors, surgeons who have already completed residency and who are looking to learn sort of a specialize in a subspecialize in spine. So feel free to contact us. Go to our website, contact HR, Human Resources, and submit your CV and an email or application stating that you want to do a fellowship with me for endoscopic spine surgery. All right. Just about done here at the left L4-5. Remember, this was the really painful disc. This was the one that was a 15 out of 10. 10 being the worst pain, she said 15. How is she doing?
He's doing good. I just need to rearrange her nasal cannula, that's all.
I could not understand a word you said.
I said I just need to rearrange her nasal cannula. She's doing
Oh,
fine.
okay.
We're so
Grab her. There's a little piece of herniation there. Nucleus material, blue. Damn it, what is that? What? You don't see the cable right there? Caught? Get that around. All right, very good. I'm gonna take a look. Everything okay, ladies?
Yeah. Get her nasal cannula in. Just rearranging the nasal cannula.
Do I need to stop or should I keep going? There's the epidural space right there. Can see it better when I put the grabber in because it kind of arrests the flow of fluid, which has a little bit of oozing of blood, and it's the red blood cells that are obscuring the view right now. So by putting that grabber in there, I'm helping to see things a little bit better just for a few moments. A lot of bone spurs here from this L4-5 level. The bone spurs are not causing pain. They're just a result of this chronic inflammation, degeneration. You guys doing all right? Do I need to stop what I'm doing? Okay, we're done here. So we're done with this level. If you feel we need to stop, we can. Come on, dilator. You guys doing all right? Have you given her any more sedation, or is that it?
No, I turned her off. I've already given her.
She's been off? Okay.
And again, so we need to switch that one. Yes.
Come back another day for the other side.
Yeah?
For 80.
Yep, we can stop.
Vitals 59.
We can stop, no problem.
1.
Let's get this closed.
Alright.
Come on, guys.
Look at the bed, Jordan. Thank you. Alright. We're okay. We're okay. We're okay.
Yeah, so we'll abort the other side. Yeah, you can do it. Not do the other side right now. We're gonna have to come back. What was your question, Diego?
Hello, everyone. My name is Diego. I am the video production manager here. Unfortunately, it seems like Dr. Deuk is choosing to abort the second level. The patient seems to be fine, and he'll be coming over to ask questions, answer questions. Thank you.
I have a very special patient sitting here next to me who's traveled all the way from Tennessee
Yes, sir.
with his family for one purpose, and that is to get his neck fixed.
In the wild, I trained animals for 25 years, not jumping through fiery hoops, but just mostly behavior, come, just a few words. We had 52 big cats, tigers, lions, leopards, cougars, lynx. This is me about 6 years ago in the tiger cage. And this guy here, we raised him from a baby.
That's special.
I'll tell you what, the special part is being here.
And how long have you been dealing with this problem with your neck?
It's come on in the last 8 weeks strong, but after I start thinking about it, even 6 months ago, I was seeing things happen that I couldn't understand why. And I just want to get back to somewhat where I was at and get the feeling back in my hands, my stability, a little strength where I can get this boy up.
Well, what's going on, as we've talked about, is you've got these herniated discs, bone spurs in your neck that are pinching down on your spinal cord and nerves. And I'm going to go in there tomorrow with a laser, and we're going to open all those spaces up, get the pressure off the spinal cord and the nerves, so you can start getting some feeling back and strength back in those arms.
That sounds great. That's why I'm here. Then I've researched, and I kept coming back to you all and seeing the testimonies and seeing, watching hour after hour after hour of the surgery. And that says a lot if you can do it live on Facebook. It's just a pleasure to be here. I feel safe. I feel like when we arrived last night, we drove up in front of the place, and I told my crew and my wife and my driver, I said, we have arrived. We have arrived. Thank you so much.
We'll see you tomorrow morning, all right?
I appreciate it so
All right,
much.
so we did surgery yesterday with the laser. Everything went really well. You can actually see the 4mm incision right there, 3 discs. He didn't want fusion, and so he found Deuk Spine Institute and he came here.
After the surgery, when I talked to her, I was still a little bit drowsy. And 4 hours later, we were sitting over at a restaurant, seafood restaurant, eating seafood, and I could clap my hands at the baby because he claps when he does something good. And I could clap with him without missing my hands.
And you're already getting strength back in your arms and legs. You're getting control of your bowel and bladder back again. That's great news. It's a great sign. I think you're going to keep improving and hopefully get you back to normal.
You are the best. That's why I'm here. That is why I'm here. It is amazing. From the time I walked into this place, I felt at home. I felt like I was with friends all the way through surgery. When we walk into this surgical room, everything's so clean. I feel like I'm in a dream. I really do. Thank you so very much for what you've done.
You are welcome.
Hello, ladies and gentlemen, and everyone watching this stream. Dr. Deuk is on his way to the broadcast station, and we will have some post-op questions and answers.
Okay, Dr. Deuk here, and thank you for joining us for live stream spine surgery. We live stream for the purpose of being able to show everybody what goes on. And for this case, we set out to fix 2 discs, L4-5 and of course L3-4. However, we ended up fixing only 1 because the time that it would require to fix the second one was, we didn't have it. Basically, the patient, as she was being anesthetized and sleeping, her soft tissues, which is your tongue and kind of like, you know, all the glands and fat in the neck, started to close off her airway, and she wasn't moving air very well. So when somebody is not moving air, that means they're not getting enough oxygen. So we were able to obviously keep her safe. She's going to do fine, but we were starting to get to a situation. It's kind of like the other day when I was watching the Formula One race. You know, it was some light rain, and all the drivers took to the track, and they were going to run the race, but then the rain started coming really heavy, and they had to cancel the race at that time, postpone it for an hour, and then come back and do the race later. So this situation with anesthesia is the same way. If you have a patient who becomes unstable because they can't move the air from their airway obstructing, you have to stop the surgery. You can't keep going. You got to get them awake. You got to get them like tightening up their muscles and everything, and basically opening up their own airway. So people breathe fine when they're awake. It's just when they sleep and they're out of it, they start to obstruct their airway, like sleep apnea. You've probably heard about people snoring. The reason people snore is that there's the passages where the air's moving start to get narrower when they're asleep because they can't tighten up their muscles and keep them open. And so the air starts to move and then get obstructed. They stop breathing, and then they wake up. So we were getting in a situation similar to sleep apnea with her, where she was not able to move air safely, and we said, that's it. We're not taking any chances. We don't want somebody obstructing and then not breathing and dying. So that would be a really bad situation. So rather than get any closer to that situation, we just decided to end the surgery. We'll come back another day, and we'll have to do the other side another day. But what we did learn is we found that L3-4 disc indeed is causing pain for her, but the L4-5, the one we fixed, was the worst one. So I think she's going to be really happy with the results for the L4-5, but I think we'll have to come back and do the L3-4 another day, you know, and just try to get it done fairly quickly without putting her too deep. So that's the explanation for the surgery. It's all about safety of the patient. The last thing in the world we want is for the patient to stop breathing because they can't move air because their airway is obstructing. So that's why we stopped the surgery. We just wanted to err on the side of precaution. All right, what questions do we have? No questions from the audience, so I hope you enjoyed watching the surgery. And like I said, most of it went very well, except for the last part we couldn't do on the right side at L3-4.